We've got an exciting program today, and I want to actually start the day with um, John Miners that will lead us. John is the Chief of Mission at the American Heart Association. He's actually Chief of Mission Aligned Businesses and Healthcare Solutions for the American Heart Association. He leads the development and expansion of the association's businesses that support its global mission to reduce mortality from cardiovascular diseases and stroke by 25% by 2025. I've had the honor and pleasure of knowing John for the last 6 or 7 years. And I must say, he's a true visionary in terms of business and how to mold science, business, and impact in the world together to create some incredibly successful programs. And I think a lot of you in the audience today have, used his products, his solutions from the AHA that has made a difference for us to improve the delivery of care. So I welcome John. It's an honor for us to have you here. I welcome you to CAHOTECH 2020 and to give the keynote. John, go ahead.
It's a great pleasure to be here with all of you. And what a fantastic topic to think about the disruption that's happening in clinical education and professional education. I think that it's a most appropriate topic, given, as you mentioned, the last 6 months have changed the way many of us in the educational world delivering education and continuing medical education. So it's a very timely topic. I'm happy to share a little bit about the way this has been approached from the American Heart Association. Our organization's been in existence for over 100 years and largely founded to fund clinical research in cardiovascular disease and strokes. I think that as part of that mission, it's not just funding science, but the implementation of that science and those guidelines that has brought us over the years increasingly into healthcare, medical professional, education. I think we've seen a tremendous amount of change in the last 10 years in particular in this area of clinical education. As you mentioned, technology is the big disruptor. It's disrupted, consumer markets and how people get goods and services. How we do discovery, how we do science. Many of us wouldn't imagine 20 years ago that the tools and things that we used would be so significantly changed and disrupted by things like mobile technology. So when I think about evolution and technology, I think about disruption. I think about not just incremental changes in a better camera or a better computer or better telephone, but the collision that happens, in disruption. So in this case, I thought I'd take an example of one of the many things the American Heart Association has done and has been known for in our resuscitation. Resuscitation is more widely known as maybe CPR and first aid. Just to provide a little background and history here, in the 1950s, CPR was developed as a clinical discipline. The practices of doing compressions on the outside of the chest to circulate blood, and to do rescue breathing and provide artificial ventilation. So in those early days, the AHA was involved in helping provide healthcare provider, typically surgeons, this sort of training. And then later it became a more ingrained part of healthcare provider training in many disciplines. Eventually, lay volunteers, as we realized we needed to start CPR earlier if we were going to, create survival in cardiac arrest. But then, this process of training people really hadn't changed much over the last 50 years. The courses were developed like we learned, medicine back in the day through instructor-led training. We trained, over this time period, over 450,000 instructors in the United States. And then in 2010, we started launching and in meeting the demand and requests for our training outside the United States. So today we have 50,000 instructors outside the United States in about 100 countries, including many in India. And we have over 60 training centers in India that are doing this emergency care training. Now, that said, in 2010, we realized there were some gaps in the way we were conducting training. I think I would describe it today as it was merely compliance. You would go take an 8-hour course and you'd get your certification card. And we really didn't have a strong understanding of, what the competency was. It was 2010 when I came to take the lead role for the emergency care program as part of my career in the Heart Association. And at the time we were recertifying healthcare providers every 2 years, and ask a simple question of, well, why is it every 2 years? And you know what? There wasn't a good answer. It was basically a logistics issue of how often would hospitals, want to retrain their staff, and there wasn't any real good science on the retention of skills. It's one thing to develop cognitive understanding and learning, but something like many medical procedures that involves actual psychomotor skills, there hadn't been much research done on. So we actually commissioned a study. And this study, led by Marilyn Ortland, was pivotal for the evolution of resuscitation and healthcare provider training. We said we wanted to look at what was the retention in the actual psychomotor skills of doing compressions and doing ventilations over time. And so we set up a control group. Basically, I trained 550 nurses, and then trained them all at the same time. And then some had monthly practice to practice their skills. And the other group, the control group, had no practice. And we then tested them at periodic time to see how competent they were. You can see here a sharp difference in the competency over time. And so the erosion of competency actually happened on the left-hand side. You see the scores on ventilation, and on the right-hand side, the compressions, and marked decrease in competency, after just 90 days. So we realized that 2 years was not the right interval for maintaining competency of healthcare providers. It was actually something more like 90 or 90 days, or at most 180 days. So that led us to thinking that instead of this typical cycle of training and skills decay and training and skills decay, we needed a much more frequent but lower dose type solution for training and providing not just compliance with training, but maintenance of competency. So we described this at the time, as in low dose, high frequency training. So more frequent intervals. Now, it's great to say theoretically and from an academic standpoint, but how do you practically do that and not disrupt or make the training so costly or so intrusive that it interrupts what we're trying to do, which is provide better care to patients? So we worked with a simulation partner. Some of you will know a company, Lærdal Medical, in Norway, longstanding partner, like Impulsus is to the American Heart Association, and they're experts in providing the hardware and software for simulation. And we thought, well, gosh, if we could put that type of solution, distributed in many places within a healthcare institution where healthcare providers could go, log in, and do their practice, and really in less than 10 minutes, but that would get real-time feedback about the competency in the same type of equipment we used in testing for that study, that showed the accurate depth and rate of compressions, that showed the accurate rate of ventilations and the volume of ventilations. These things we know from science are essential to high quality CPR, and that high quality CPR, if you do it accurately and with precision, leads to dramatically better outcomes and survival from cardiac arrest. So this launched what we now call the Resuscitation Quality Improvement Program, where we launched this program, if you will, in 2015, and since that time we now have 1,800 hospitals in the United States that have converted to this type of training. I hesitate even calling it training anymore. I think the paradigm shift here is that we have moved from just compliance of taking course hours or continuing medical education, and we've gone past just online e-learning and digital, remote learning solutions to now this idea that you combine the micro simulation or online, cognitive learning periodically with more rapid, low dose, high frequency skills verification, I would say. We're moving now toward not thinking of just competency maintenance, but verified competence. So really exciting times for us. We've reached, now that, as you know, there's about 500 healthcare institutions in the United States. We now have a third of them that have moved to this, including every U.S. Veterans Administration hospital is converted to this. We expect to double that number this year. COVID-19 provided an unprecedented opportunity and challenge to the healthcare community in trying to do continuing medical education. Nobody wanted to convene their healthcare providers and put them in a classroom and add to their risk for infection by not social distancing. So the unique piece about RQI over other modes of continuous learning is that it was completely autonomous. One healthcare provider and one machine. We had to do some cleansing of the machines, but it has the unintended benefit of also protecting healthcare providers while maintaining their competency, but by not having to be in a classroom environment. One interesting part of this, and several months ago, we realized the potential benefit beyond just competency, but protecting healthcare providers. So we started offering this free to hospitals that weren't using it already. We're not a commercial company at the American Heart Association. We're an NGO, not for profit. So this was mission oriented, and it was something we thought we could contribute in the global, fight against the pandemic. And in fact, over 400 hospitals have taken us up on it to date, and several more are in the process of taking this on and trying it and using it as a way to not let their healthcare provider competencies erode, but continue this in a much more safe and automated way. So this idea of moving from compliance to competence is, I think, one of the major themes that we'll see as we're leveraging these technologies, not just, as I said here, online learning or online simulation, but then the simulation technologies as they're evolving. Artificial intelligence, as Samir mentioned. I like to think of artificial intelligence as augmented intelligence because, I think that it's really supporting human beings rather than something being, completely automated. So I mentioned this opportunity that we provided these units for free to hospitals, and I thought, the best testimonial is hearing from one of those hospitals and what they had to say about it. So let me share a bit about that and their feedback.
Here at St. Charles, we used a traditional model of classroom teaching, pulling caregivers off the floor and teaching classroom-style presentation. It was a pretty costly model and difficult to manage the amount of instructors that we needed.
Getting somebody to a standard CPR education class in a classroom is always a challenge. It was very difficult to schedule to get people in there because you had to cover their shifts. And so not only are you paying for their time there, but you're also paying for someone else to cover them. People only got to practice once every 2 years. And so they really weren't that proficient when it comes down to actually doing CPR.
When the pandemic hit, our command centers came to us and said that all classes would stop. I knew we would have 800 to 1,000 caregivers to certify, and I didn't know how we were going to do that.
The staff themselves became very stressed. We have if you don't have your certification, you don't work policy.
At St. Charles, we brought in the We Can Help model, which is dramatically different than our old traditional model. They didn't have to come to a classroom. They did tutorial online learning and then performed their skills at the RQI station.
When the We Can Help came about, that was revolutionary for us to be able to get people the certifications they needed.
When I first introduced the program of RQI to the caregivers, they were terrified. I got comments like, how am I going to do a mega code? Who's going to evaluate my skills? But as we moved along the continuum and they did their virtual online learning and they practiced their skills at the cart, they began to see how easy it was and how much it supported evidence-based practice.
RQI is going to really open the door for the staff to be much happier. We can actually set them up to be able to do this while they're still on shift. They take a break, they go down, they do the computer part, they do the hands part, and we can actually incorporate that into their regular workday.
At St. Charles Health System, we are trying to increase our survival rates for in-hospital cardiac arrests. And RQI is a driving force in that because it increases caregiver competency and confidence by 98% after the first year. And we're able to monitor that through the RQI data and quality process.
One of the benefits of using the RQI over the classroom system is in the classroom system, we have the diversity of those who do it all the time and those who never do it. With the RQI process, that gap is closed. That provides consistency across the system. So no matter where the resuscitation needs to occur, the response is always strong.
We saved $1 million a year. So in the middle of a pandemic, we were saving money by bringing in We Can Help and RQI.
If I was talking to another ED manager in a system about RQI, I would tell them that they're going to have happier staff. They can just get to use RQI on shift, and they're going to be better trained because they're doing it more frequent. And you're going to provide better care at a lower cost.
It was like a perfect fit. Bringing RQI in is now our new normal. And moving forward, that will be the new norm.
So hopefully you can see what I'm talking about this disruptive technology and how this convergence of technologies is shaping we believe the world of healthcare provider education will be forever changed, particularly in resuscitation, but as this gets applied to other disciplines. I thought I'd share here just a little bit of the actual competency improvement. And you can see the scores in the blue from their first test, and then after this continuous low dose, high frequency, how consistent and high scoring their compressions and ventilation scores were. Those of you that know anything about resuscitation science know that it is the acuity of the compressions and ventilations that determines survival from cardiac arrest. So some of the hospitals, while these studies haven't been published yet, I can tell you generally, many of them are seeing double-digit increases in cardiac arrest survival, some as much as 20 or 25%. So we'll be looking at these studies as they are published later this year, and very excited about the results and this evolution and change. I think I'll kind of wrap it up by saying I'm so excited about the future of healthcare provider competency and education. Technology has the opportunity for us to not rely on compliance and just continuing medical education and online learning, but to provide verified competence and feedback. Samir mentioned about wearables and the opportunity there, big analytics and big data and analytics. And I think ultimately, more and more devices giving us the opportunity to, in real time, get feedback about our patients. Remote monitoring is something that I think will be hugely important in the future. And you think about another disruptive technology. When I went to school and we learned to drive, they taught us how to read maps. You know, my grandkids are going to school now, and I said, "Do they ever teach you how to use maps?" And they said, "No." They teach us how to use a GPS, because everyone has a GPS either in their vehicle or in their phone. No need to read a map anymore. So when I think of medical education and healthcare provider training, I think of that. I think that the ways that we do it today are going to be extinct very soon. And the types of real-time data informed augmented reality, augmented intelligence is going to shape the way that healthcare providers do their work increasingly in the future. So thank you very much.
Great. Thanks, John. That was good. That was great. I mean, stuff that I was talking about, IoT devices. I mean, your mannequin is an IoT device, right? And you know, the data piece going back and forth. And I mean, I think there's a couple of questions. One question that the audience has asked is, I mean, the RQI system is great. And you know, when do you think that system will actually come out in Asia and in India in particular?
Yeah, it's a great question. So we have just started implementation in other parts of the world. There are pilots now in the UAE and in Saudi Arabia. We don't have a pilot yet in India, but I think it's coming very soon. Places like Ireland have converted that have been doing AHA training for decades. I've completely converted to this. So it's beginning to happen outside the United States. Now that the solution is more than a minimally viable product, it's a very mature now, ready to scale solution.
And there, another question, I think, what people are, one of them is asking is actually, you know, the ACLS and BLS certification. Is there any opportunities of actually bringing the cost of that down so that more people will actually be able to get ACLS and BLS certification in a country like India?
Yeah, you know, that's the one thing about instructor-led training is it's very expensive. You know, it's not just the cost of the instructor, the materials, but it's the healthcare provider's time when they're away from the bedside caring for patients. You heard the hospital in the video; they saved $1 million in time and resources. So this dramatically lowers the costs of overall costs of doing medical education by allowing it to be done in low doses, you know, not time away from the bedside. So we think it's disruptive in that way. It's not only more effective, but more efficient.
And I'm going to wrap it up with one more question. Ensuring CPR compression efficacy is challenging. Definitely more scope for further developing 100% online platform for BLS or ACLS e-learning. What's AHA's long-term vision to ramp up the certification program in India?
Yeah, that's a great question. I think that we're training about 2 million healthcare providers in India today, and through the network of training centers that I said, but they're all doing the traditional instructor-led training for things like ACLS, BLS. We would like to see, you know, the digital online learning, you know, the middle component of that, and the RQI solution, you know, completely replacing that, just like it will in the United States. I believe we'll have full implementation in the United States within 2 years. We want to start and are already making efforts in India to introduce these new technologies and rapidly, you know, transform you know, that discipline, that industry.
Great. Thank you very much, John. I think it was a great session to really incorporate all the things that, you know, that paradigm shift. I mean, this shift that we saw in ACLS and BLS certification is exactly what we're, you know, what the theme is today. And thank you for all your great work and across the world.
My pleasure. Thanks for having me.